Hello, everyone, and welcome to ISGyP Live's Journal Club for September 2021. The theme this month is uterine mesenchymal tumors, and I'm your moderator, Natalie Banet. While participants are joining on and we give people time to join, I will go ahead and take care of some housekeeping events for ISGyP Live. So I wanted to talk about some upcoming events, including the Interesting Case Presentations Conference, which is the second month. And that's moderated by Dr. Jennifer Bennett and presented by trainees, and that'll take place September 22nd at 1300 or 1 o'clock US Eastern Time. And the next podcast will be on September 29th. That's moderated by Dr. Parharan. And the theme is the ISGyP Endocervical Adenocarcinoma Project. So this is part 2 in the series of these podcasts and covers staging recommendations, and it will feature Dr. Kay Park. I also wanted to speak briefly about the first annual ISGyP annual conference, which is entirely virtual and presented on Zoom. It's on Saturday, or it's presented on Zoom, sorry, and it's present on October 16th, 2021. And the theme is WHO 2020 and Beyond, Refinements and Diagnoses of Selected Female Genital Tumors. This will feature 16 international speakers speaking for 20 minutes in a case-based format with live moderated questions and answers. And it's free to the general public. So just keep that in mind if you want to stick that date on your calendar, and details will follow. And if you want to find out more about these events, you can register for the first two at isgyp.ca. And this last one, details will be emailed to ISGyP members. And for those who are not ISGyP members, I would check the Twitter account for ISGyP. Okay, and then just briefly, if you are a trainee or if you have trainees, we do want to hear from you all and involve you. So myself and Dr. Karen Talia are the moderators for Journal Club. Dr. Talia moderates every other month to make it more friendly to those in the Eastern Hemisphere. So she'll be next month. And then Dr. Jennifer Bennett. So our contact information is here if you'd like to reach out to us for you or your mentor to present. And we do mentor and practice ahead of time. So if anyone is nervous about that, I think we do a pretty good job making people ready for the day. So I'd like to introduce today's speakers. We have first up, Dr. Yevgen Chornenkyy. He is a PGY3 at Northwestern in Chicago, Illinois, and sadly is not pursuing a career in GYN pathology, but I can't wait to hear from him today in his presentation. And Dr. Evan Goyette, he is also a PGY3, but he's at Dartmouth Hitchcock Medical Center in Hanover, New Hampshire. And Dr. Goyette is pursuing a fellowship in GYN pathology. So we're happy to see him at this early stage of his GYN career. And Dr. Shaza and Khadra, who is a PGY2 at Brown University or Rhode Island Hospital in Providence, Rhode Island. And she's only a PGY2, so I consider her pluripotent, but I'm trying to lure her to a career in GYN pathology, so we'll see how that goes. So this month's theme is uterine mesenchymal tumors. And first up is Dr. Chornenkyy presenting this paper by Bennett and colleagues, which he will review. And then Dr. Goyette will present his article. And then Dr. Khadra will present her article, and I'll let them talk about the titles and the topics so that we're not repeating ourselves. Every month, I just like to put up learning objectives for Journal Club to remind people that this is a trainee-centric activity that we are offering to provide opportunities for trainees and young members from all parts of the globe to volunteer and present, and we provide mentorship, and we really want to engage future leaders in the field from around the globe. This is the format of the PowerPoint that the presenters are going to use to present their findings. If you would like to take a screenshot of it to just follow along, but this is the template that they're following and critically evaluating these pieces of literature. So this is our schedule I've already hinted at today. I will talk, Dr. Devins, that was last month, I apologize. So I will talk for a bit, then our three presenters, and then at the end we will have wrap up and questions, and time permitting between the presentations, we will have some polling questions, and I will explain that as we go. For the webinar format on Zoom, most people are probably familiar with it by now, but if you would like to post a question for me or one of the presenters, there is a Q&A box in the black bar at the bottom of your screen, so you can type in your questions there. You can use this chat function for comments that you want the presenters to be able to see, but if you put your questions there, sometimes they get lost. So the Q&A is a better place for that. And if you see someone else that has put a question that you like, you can always upvote it to let me know to prioritize that question. So that's all for now. I will stop sharing my screen, and we can have everyone except Dr. Chornenkyy turn off their cameras because it's your turn to present.
Okay, I'm just going to go ahead and share my screen. and go full screen in my PowerPoint. Can everybody?
Yep, it looks good.
Okay, great. Hi, my name is Yev. It's a pleasure to be here and present for you today. And the article I'll be talking about is, very briefly about me. I'm a third-year resident at Northwestern. I'm pursuing GI and hepatology fellowship at Israel, and my academic interests include medical liver, transplant pathology, and blood banking. The article that I will be presenting is titled Uterine PEComas, Correlation Between Melanocytic Marker Expression and TSC Alterations, TFE3 Fusions. And it was published in Modern Pathology in 2021. So briefly, for the introduction, I'm going to talk about uterine PEComas, but then I'll show some histology images of them. So uterine perivascular epithelioid cell tumors are also known as PEComas. They are mesenchymal neoplasms with morphology that overlaps with smooth muscle tumors. PEComas express melanocytic markers and smooth muscle markers, but smooth muscle tumors can be positive for HMB45 too. A previous study before this paper looked at 17 uterine mesenchymal neoplasms with myomelanocytic differentiation, and using molecular immunohistochemistry and morphology, they were able to categorize them into 4 categories. They were malignant PEComas, sarcoma with PEComa-like features, and myogenic sarcoma and sarcoma NOS. But they weren't very clean subgroups, and some TSC alterations or TFE3 fusions were detected in primary or recurrent tumors. Only one malignant PEComa lacked TSC or TFE3 fusions, but contained higher than HMB45 expression. So this study builds on that to try to define the molecular findings and the degree of melanocytic marker expression in 19 cases previously diagnosed as PEComa. So what are PEComas? What do they look like? You could see that they can show like a nested architecture on low power, which is very prominent over here. But here it's a lot more subtle. PEComas usually are composed of epithelioid cells with variable kind of eosinophilic to clear cytoplasm. And on high power, you could see that the nuclei are generally like round to ovoid, and they have like these punctate small nucleoli, and the cytoplasm has this kind of like characteristic moth-eaten, frayed, or stringy pattern associated with it. So briefly, let's talk about the overview of methods and the results of the manuscript. All cases were selected had an initial diagnosis of uterine PEComas using the algorithm, and I'll touch upon what the algorithm means in the next slide. 13 were classified as tumors that have uncertain malignant potential, and 6 were classified as malignant. 6 out of 18 recurred, and the initial categorization for them was 1 was UMP, which is uncertain malignant potential, and 5 out of 6 were malignant. 6 out of 19 patients with malignant subtype, 3 were passed, and 3 were alive with disease at the time the study was published, and 13 out of 19 patients that were diagnosed with tumor of uncertain malignant potential were alive with no evidence of disease. So what is the algorithm and what does it mean? To classify something as malignant in this study, the authors said that it must meet 3 criteria. It must be greater than 5 centimeters, have necrosis, have a high nuclear grade, and must have greater than 1 mites per 50 high-power fields, as well as vascular invasion. Tumors of uncertain malignant potential are defined as only having a single histological feature, like of nuclear pleomorphism or multinuclear giant cell, for example. And if a tumor is greater than 5 centimeters, it is automatically at a minimum of uncertain malignant potential. So I'm going to summarize the results on this slide, and then we will walk through the results and the figures kind of one by one. In the kind of the bird's eye view here is that there were 19 PEComas in this study. 6 out of them were malignant based on the algorithm previously mentioned. 3 of those malignant patients were passed at the time of the study, whereas 3 were alive. All patients with uncertain malignant potential were alive at the last follow-up, which was 47 months. Majority of these neoplasms had a TSC1 or 2 alterations. 1 out of 19 had a TFE3 rearrangement, and 1 had no mutations. HMB45 expression was strong and positive in greater than 50%, in majority of these cases. And 1 out of 19 of these tumors had less than 10% positivity, but the tumor lacked TSC1 or TFP3 mutations. Melan-A and MITF had showed like variable staining, about like 20% intensity in majority of the cases. And using molecular analysis, like sequencing and copy number alteration arrays, it was found that 5 out of 6 malignant PEComas had alterations in TP53, ATRX, or retinoblastoma. None of these findings were found in the UMP tumors, and also 1 of the malignant PEComas contained a mismatch repair deficiency. So here is a molecular NGS that the paper presented as one of the figures. And you can see that here's all the PEComas listed from 1 through 19. The malignant ones are highlighted in red. And you can see that ATRX and TP53 are mutated or altered in these neoplasms recurrently. So it's present in these. TSC1 and 2 alterations are present in majority of them, and they appear to be mutually exclusive because TSC1 is in the mTOR pathway, so it seems like as long as there's a 1 hit on the mTOR pathway, it doesn't matter whether it's TSC1 or TSC2. There was also a copy number alterations analysis, and the blue box demonstrates copy number loss. You could see that in the recurrent copy number losses in the malignant cases, which are again highlighted in red, are retinoblastoma and P53. And overall, when you take together the sequencing and the copy number alterations, majority of the malignant PEComas harbored alterations in TP53, ATRX, and RBE1, which is important, and I'll get to why this is a significant and can be used as an application in clinical practice later near the end of PowerPoint. So all tumors, regardless of TSC status, had HMB45 staining intensity with a mean of 72%, with majority showing very strong intensity. In TSC altered PEComas, HMB45 staining intensity ranged from 15 to 100%, but the mean was high. It was about 70%. And Melan-A and MITF were positive in majority of the neoplasms, but the mean staining intensity was about 20%. The neoplasms that had no TSC alterations, the first one had a PSF TFE3 fusion and was positive for HMB45, but Melan-A and MITF was negative. And a second had a complex morphology, which was like epithelioid cells with eosinophilic to rhabdoid cytoplasm. It was also spindled, and it was positive for HMB45, Melan-A, and MITF. One of the cases had was microsatellite unstable and contained a loss of MLH1 and PMS2, and it also met the malignant criteria. The remaining of the cases, the mismatch repair pathway was intact. So let's talk about what these results mean and how can they be applied in clinical practice. So PEComas must demonstrate at least 2 melanocytic markers, but because of overlap with smooth muscle tumors, this study compared genomic markers with melanocytic marker expression. All tumors express at least 2 melanocytic markers, but Melan-A and MITF were not helpful as no correlation was observed between TSC alterations and expression. TSC2 or TFE3 alterations were identified similar to previous studies, although some samples did not fit the criteria neatly as expected, and this could be likely secondary to other possible mTOR pathway alterations that were just not picked up in the study. And then TSC alterations are possibly specific to PEComas, and when identified, mTOR inhibitors can be used. The molecular studies in this paper allow for risk stratification. So for example, if you have a PEComa and you have access to an NGS platform, you could send it for sequencing, and you could see that if it has TP53, ATRX, or RB1 mutations, it is much more likely to be a malignant PEComa and have potentially worse outcomes for the patient. Again, TERT promoter mutations was present in recurrent UMP PEComa, so again, this helps with risk stratifications. And MMR loss was in PEComas was a positive finding because these patients could benefit from PD-L1 inhibitors. So the strengths of improvement, this is not so much like a weakness of the study. It's just that whenever we sequence it, something, or we do like a sequencing study, we are limited, or we only see what we are looking for. And in this case, these authors used a 1,213 gene OncoPlus panel at University of Chicago. And while I have the panel over here, this is from their website. It's a great panel, but there's also other options for sequencing. Tempus over in Chicago, I believe they offer a whole exome panel, so it's able to pick up any kind of other things that could not be picked up by this panel. And also the Mayo Sarcoma Fusion panel can pick up other alterations that may have been missed by this panel. But the only, I guess, the thing to mention here is that the sequencing is very expensive, and again, these panels are probably more expensive than the Chicago panel, and so that's something just to consider and take into account. But overall, this is a great panel. And here are some of the applications of the manuscript, and I really like that the authors included this figure because it really helps to summarize the manuscript. And if you have a mesenchymal neoplasm with myomelanocytic differentiation and it has a TSC alteration, it is likely a classic PEComa. If it has a TFE3 fusion, it's a TFE3 translocation associated PEComa. If there are no molecular alterations, but the HMB45 staining is of high intensity, you could favor a PEComa. But if these are not present, you can go with a descriptive diagnosis. So this is, I thought this was very helpful to include. And my two take-home away points for this paper is that TSC or TFE3 alterations are identified in most of uterine tumors morphologically and immunohistochemically compatible with PEComas. And majority of them have high intensity and also high expression of HMB45. Also, most malignant PEComas harbor additional molecular alterations in P53, ATRX, or retinoblastoma, and rare PEComas can have mismeasured MMR deficiencies, which I think could be also tested by looking at on the protein IHC expression panels. And thank you for listening to the presentation and being here. I really appreciate you being here. Here is a picture of us, some of our residents going to hike at the Indiana Dunes National State Park. So thank you so much for having me, and I'd love to answer any questions.
Great, thank you. You can stop sharing now. There is one question already for you in the Q&A, which you're welcome to answer, or I can take a first stab at it, but it's in the article. Dr. Tafe is here in the audience, and she is wondering, was the loss of MLH1 PMS2 expression in the PEComa due to MLH1 methylation indicating sporadic deficiency, or was this not tested?
Thank you for the question. I'm actually not quite sure. I would have to go back at the paper and look at it again. Well,
lucky, because while you were talking, I was able to do that. That's why there's two of us. They said next-gen sequencing showed microsatellite unstable and loss of MLH1 and PMS2, and they favor that this was MLH1 promoter methylation. So it doesn't sound like it was tested, but that's what they favor because, you know, that's how, when both of them were lost, obviously. So I think that's a good question. And then they also comment that this maybe warrants further testing because of, you know, possible therapeutic implications for the patient. So that's good. Okay, and now I will launch the polls because I think we have enough time. Yes. So those in the audience should be able to see the polls now, and you can start voting. And for those watching the video, I will put them up on the screen for you to be able to read them. They're exactly the same. Okay, I'll just a few more seconds. Looks like we have quite a few people voting, so we'll just wrap it up here in the next few seconds. Every month I try not to make these questions too wordy, and I think I'm just constitutionally incapable, so I know it's a lot to read through. Okay, and so now I'll share the results, and it seems like the first question, which of the following is true regarding uterine PEComas? I tried to make it relatively obvious. The first two choices are wrong. Their morphology is not distinct from smooth muscle tumors, and melanocytic markers can be positive in smooth muscle tumors. They are frequently associated with mutations in the TSC gene, so that is the correct answer. And there have been gene mutations of TFE3 described. So the second question, which of the following was noted in this study? The first choice is correct, which I think, let's see, 83% of folks got that right. Most tumors showed either a TSE or a TFE3 alteration. And then the last three are just distractors. And we've already talked about the last one. The biphasic tumor did share mutations, and then there were additional mutations like P53 that Dr. Chornenkyy discussed. So I think there are some additional questions that came in, but in the interest of time, I will go ahead and stop sharing, and we'll have Dr. Goyette come up, and then at the end, we'll bring your question back up and we'll all talk about it. So, right.
Okay. Is my screen being shared?
Yeah, I can see you and hear you. You're good to go.
Excellent. Again, Dr. Banet, thank you so much for having me today. Once more, my name is Yevgen Goyette. I am a third-year pathology resident up at Dartmouth-Hitchcock with Dr. Tape, who's already commented on our chat today. And our next foray into rare uterine mesenchymal neoplasms will be regarding inflammatory myofibroblastic neoplasms with aggressive behavior, including an epithelioid inflammatory myofibroblastic sarcoma. And this piece of literature came out of MD Anderson with Dr. Katrina Collins as the first author. A little bit of background on uterine IMTs. These are neoplasms that possess a myofibroblastic phenotype with variably prominent myxoid matrix, as you can see in the photomicrograph on the top right of the screen. They also characteristically have a prominent inflammatory infiltrate that is usually lymphoplasmacytic. And lastly, they have recurrent ALK gene rearrangements. Up to 90% of these, greater than 90% of these tumors do. Importantly, these are very rare tumors to be encountered in the female GYN tract. The most common location is the uterus, and there are rare case reports described in the ovary, fallopian tube, and cervix. Generally, these tumors behave in an indolent fashion. About 70 to 75% are cured with surgical resection alone. However, a significant subset display aggressive clinical behavior, and we aren't quite sure why they do that. So the objective of this study was to characterize the clinical pathologic features of uterine inflammatory myofibroblastic neoplasms that behave poorly. So our colleagues down at MD Anderson reviewed their pathology archives for over a 9-year period with search terms IMT and uterus, and any case that showed evidence of recurrence or advanced stage disease, be that clinical, radiologic, or pathologic, were selected for analysis. And once these cases were selected, they conducted quite a thorough examination of both the clinical features and the histopathologic findings. So I'm going to show 3 of the results tables, and all 3 of them are similarly arranged such that the case number is on the left-hand side of the screen. And just for your reference, cases 1 through 8 were the aggressive IMTs, while case 9 is the EIMS that was presented as well. So first, we'll just discuss the age range, predominantly perimenopausal, with the one exception being a 32-year-old who was diagnosed with this. And the predominant clinical presentation was quite nonspecific, with abnormal uterine bleeding, pelvic pain, nothing that pointed specifically to this diagnosis. This next panel, I do want to point out the column of initial diagnosis. So the majority of these tumors were seen at MD Anderson in consultation. And the initial diagnoses were a range from benign diagnoses. You can see the leiomyomas with degenerative change, all the way up to, frankly, malignant, with leiomyosarcomas being the most commonly rendered diagnosis. And in fact, only one of these tumors was called IMT up front. And this really illustrates the diagnostic difficulties that this particular neoplasm presents. This last panel, I want to highlight the sites of recurrence being predominantly abdominopelvic, with just rare examples being supradiaphragmatic. The time to recurrence ranged from 3 months up to 5 years. And unfortunately, these aggressive behaving inflammatory myofibroblastic neoplasms are deadly. 3 of the 9 patients studied did die of disease. Next up, we'll discuss the pathologic features of these uterine IMTs. First, the size ranged from as small as 4 centimeters up to 15 centimeters with no really clear skewing one way or the other. The borders of these tumors were predominantly infiltrative. However, there were a couple examples where the borders were well circumscribed, not what you would expect out of an aggressive behaving tumor. Next up, we'll discuss the really wide range of nuclear and cytologic atypia that was described. An even smattering of low-grade to high-grade predominating forms were identified. Again, not what you would expect with aggressive behaving tumors. In the same vein, the mitotic indices were low compared to what you would expect for an aggressive behaving tumor. Only one broached double digits per 10 high power fields. I do want to just say a word about how nuclear atypia was defined in this paper. And the authors used the framework that was first established by our colleagues up at MGH in this paper that was published in 2015. So briefly, grade 1 or mild atypia can be appreciated at 40x magnification. These spindle cells are about the same size as endothelial cells, and they really aren't terribly pleomorphic. Again, we're up at 40x, and it's really quite hard to appreciate any atypia here. Contrast that with grade 2 or moderate atypia, which can be appreciated at 20x. We're starting to see increased hyperchromasia, increased nuclear pleomorphism. And then we can accelerate all the way up to the severely atypical nuclei, which even at 10x, we're seeing these really ugly bad actors, hyperchromatic, very large, and quite obviously severe. Lastly, regarding the pathologic features of these tumors, I do want to point out the absence of lymphovascular space invasion that was found in all cases of aggressive IMTs. For tumors that are recurring or metastasizing, I think we all would expect to see some LVSI. We did not, and the authors did not see that here. Lastly, a quick word on the ancillary testing performed on these. If we're first looking at the immunohistochemical panels that were ordered, I want to focus primarily on ALK1 and the staining pattern. Again, greater than 90% of these tumors have ALK1 rearrangements that result in ALK1 overexpression that can be seen immunohistochemically. And indeed, 8 of the 9 cases showed ALK1 positivity, the IMTs showing specifically cytoplasmic and granular staining. The one case that did not show ALK1 positivity did show rearrangements via FISH and also fusion proteins via whole exome sequencing. Again, depending on where these specimens came from, they either did or did not have ancillary studies performed on them. But by and large, there was at least one of the 3 ALK1 immunohistochemistry, FISH, or NGS was positive for in these tumors. I do want to point out some of the photomicrographs because I thought they were quite interesting. 5 of the 8 aggressive IMTs appeared identical histomorphologically when they recurred. However, 3 of them did not and showed evidence of histologic progression. So this first example, the top 2 panels are the primary uterine IMT. And you do see kind of the classic morphology. We have this myxoid stroma with predominantly lymphoplasmacytic infiltrates. This is an example of the fascicular growth pattern that could also be seen. We still see some myxoid background here in these generally bland spindle cells. However, the metastasis, and this was a lung metastasis, is markedly different. We see a lot more epithelioid cells that are showing variations in nuclear size and shape. They are additionally a bit more hyperchromatic as well, given this was given a grade 2 or moderate nuclear atypia. So evidence of progression in this example. The other 2 cases that changed when they recurred or metastasized displayed this pattern, whereas the primary tumor is, again, generally bland spindle cells in a myxoid stroma, to becoming more fascicular in its growth pattern, with increasing levels of cellularity and atypia as it recurred. Especially this one, we can see a mitotic figure, some prominent nucleoli, even at this lower power, looking much more cytologically atypical. And lastly, to mention this epithelioid inflammatory myofibroblastic sarcoma, this is actually the first described case of this entity in the uterus. And the histology is quite interesting. We have epithelioid cells in a myxoid to hyalinized stroma. At high power, we're seeing these really grade 3 nuclei. They are large, they are vesicular with multiple prominent nucleoli. We're seeing kind of a variable inflammatory infiltrate that includes eosinophils, curiously. And lastly, this final panel shows the unique staining pattern of ALK1 in these tumors, whereas IMTs show a cytoplasmic and granular stain. EIMSs described in other body cavities generally show a ring-like perinuclear staining, which was also appreciated in this case. So our go-to GYN textbooks generally think about aggressive behaving IMTs as being very large in terms of the primary tumor size, having moderate to severe nuclear atypia, high mitotic activity, and lymphovascular space invasion. Really buzzwords that we think about as being markers of aggressivity in not just mesenchymal tumors, but also in carcinomas as well. However, this paper that we've just reviewed is kind of suggesting the contrary. In terms of the size of these tumors, it's kind of an even split between tumors that were relatively small, 4, 5, 6, to ones that were larger. While the borders were predominantly infiltrative histologically, there were 2 examples of well-circumscribed tumors that recurred or metastasized, which is not what you would expect. Furthermore, the nuclear atypia could be anywhere from diffusely bland to obviously atypical, and you would not expect these bland tumors to behave poorly. Similarly, with the proliferative indices of these tumors, if you told me that there was a tumor that had low-grade nuclei with only 1 mite per 10 high-power fields, I would not expect that to be metastasizing and going anywhere. Lastly, the complete absence of LVSI is also a little concerning from a pathologist perspective. We don't think this is going to go anywhere because it's not showing a propensity for it in the primary. So wrapping up the ideas presented in this paper, aggressive uterine IMTs are, of course, rare tumors to find in the GYN tract. They occur predominantly in perimenopausal women, and they tend to be mistaken for smooth muscle tumors that are particularly those that have myxoid stroma. Importantly, pathologic parameters do not reliably predict behavior in these tumors because they can be deceptively bland and can adopt morphologies that we would not associate with aggressivity, as you can see listed here. In terms of the strengths of this study, this is the largest case series to date of aggressive inflammatory myofibroblastic neoplasms, and it required quite a search back into the archives to do so. So the authors should certainly be commended for acquiring enough cases to conduct a study such as this. Furthermore, I thought that their clinicopathologic review was quite extensive, and they took really a no stone unturned approach to analyzing these tumors. I wasn't wanting for any additional information when I read through each case. In terms of areas of improvement, I do think that their inclusion criteria was slightly rigid, especially when you account for the frequency of misdiagnoses. We saw in that first table that 8 out of these 9 tumors were misdiagnosed initially. So you wonder if we missed some IMTs that were misdiagnosed just in the archives. The second point I'd like to discuss is the necessity of including the EIMS in this paper. It's an incredibly unique tumor. This was the first time that it's been just really described in the uterus. And unfortunately, I thought that the details were kind of buried behind the data regarding the aggressive IMTs. So maybe a different format of presenting the IMS would have done it better justice. And lastly, the thing I was maybe missing the most was postulations on other prognosticators of aggressive behavior. We've kind of debunked the theory that our classic histologic parameters can help us predict behavior. So is there anything else that we should be looking at? Particularly, I was thinking about the wealth of NGS data that we have on some of these tumors. Maybe there are other molecular signatures that could help us predict which IMTs are going to behave poorly. So in summary, the lessons that I learned in this, after reading this paper, is that when dealing with a spindle cell lesion of the uterus with unusual morphology, particularly when there is myxoid matrix involved, do not forget about IMT. When available, use ancillary studies liberally, both IHC, FISH, and NGS. And for now, most importantly, it's imperative that we recommend close clinical follow-up when we render a diagnosis of IMT, because we just can't predict when these are going to behave poorly. So once again, thank you all for attending the talk today. I really appreciate you taking the time. Thanks.
Thank you. Excellent job. There is one question which you're welcome to take a shot at, or I can, just let me know. Someone wants to know, do you have multinucleated giant cells in IMT of the uterus?
You certainly can. And that was one of the examples in the paper, not a photomicrograph that I did not share, but they have a very nice photo where multinucleated giant cells are present.
Yeah, so these things really can wear many faces, or whatever the expression is. Okay, so now we can go for the polling questions, which I will launch. No, I hope I will. Let's see. I see. There we go. All right, you should be able to see them on your screen now. And for those watching the video, I will pull them up. Same question so you can see them as well. It's like watching a horse race with the second question. A few more seconds and then we'll answer these. Okay. All right, so I'll share the results. Okay, so for the first question, which of the following is true regarding IMTs of the gynecologic tract? Like I said, I usually try to put distractors in there, but the true answer is other sites have been described, including the ovary, cervix, fallopian tube, and placenta, but the uterus is the most common site. There are targeted therapies for IMTs. Most cases do show abnormalities of the ALK gene, and most IMTs of the gynecologic tract are indeed not malignant. So which of the following was noted in all of the aggressive IMTs in this study? And I put this question in here to sort of reinforce the point that Dr. Goyette was making, that really a lot of them showed grade 1 nuclear atypia, epithelioid morphology, which is something that we, sort of, not just in IMTs, but in other mesenchymal lesions of the gynecologic tract, we sort of associate with more aggressive behavior, like in smooth muscle lesions and things like that. Not all of them had that. And then LVI was not present in almost all of these cases. The only thing they all had was inflammatory infiltrate, which kind of goes along with the name. So not sure that that's really that helpful. So I just was trying to demonstrate that the histologic parameters that we sort of apply to other lesions are not seeming to work quite as well here. So did you have anything else to share, Evan, or does that seem reasonable?
No, that was good.
Okay. All right. So yeah, thank you for your presentation. And Let's see, so we can go ahead and have Dr. Khadra share her screen, which requires me to stop. So you're up.
Hello?
Yeah, we can hear you and see you. You're good to go.
Okay. Hi, everyone. My name is Shaza Khadra. I am a BGY2 from Brown University at Providence, Rhode Island. Today, I will be presenting at the Journal Club this article. It's uterine endometrial stromal tumors with limited infiltration. This is the first report of a case series indicating potential for malignant behavior. It's about 19 cases by Moore and McCluggage. It was published in May of 2020. First, I will start talking a little bit about the endometrial stromal sarcoma. They are very rare. It's approximately 10% of all uterine sarcomas. It's approximately 0.2% of all uterine malignancy. Patients age about 55 years old. They are usually asymptomatic. However, sometimes they present with abnormal vaginal bleeding, pelvic mass, symptom related to extrauterine spread, which is most likely to the ovary. The recent WHO classification divided these tumors into 4 categories: endometrial stromal nodules, low-grade endometrial stromal sarcoma, high-grade endometrial stromal sarcoma, and undifferentiated uterine sarcomas. With the most common of all of them is the endometrial stromal nodules and low-grade endometrial stromal sarcoma. And I will be mostly focusing on these 2 in this article. What we see on a gross examination, in this image here, we appreciate this well-circumscribed mass, and we see it's tan yellow, soft, on a cut surface with these cystic changes. And this represents a well-circumscribed endometrial stromal nodules. On the other hand, on this image here, we see a poorly defined multinodular mass, which has also tan yellow cut surface. But here we see in the myometrium worm-like plugs filling the myometrial vessels. And this is the key for diagnosing low-grade endometrial stromal sarcoma. On the other hand, on microscopic examination, here we see a relatively well-circumscribed proliferation of a small uniform blue cells with a scant cytoplasm, oval nuclei. This represents the well-circumscribed endometrial stromal nodule. In this image here, we see an irregular islands infiltrating through the myometrium. It also has similar low-grade cytologic features, but however, here we see the infiltrative through the myometrium, which we don't see in the well-circumscribed endometrial stromal nodule. This case represents a low-grade endometrial stromal sarcoma. Both cases, they actually have similar molecular events. However, the way in distinction between these 2 tumors, grossly and microscopically in the way they interface between the myometrium. Also, low-grade endometrial stromal sarcoma, they sometimes have vascular invasion, and it helps to establish the diagnosis if it's present. We don't see lymphovascular invasion in endometrial stromal nodule. Clinically, endometrial stromal nodule, they are benign, they don't recur or spread. However, low-grade endometrial stromal sarcoma, they have low potential malignancy, they can recur, and they can spread to other organs other than the uterus. So the study here aim to categorize endometrial stromal tumors with limited infiltration and provide details about the clinical behavior for this rare entity. But first, They refer to an old paper. It's in 1981 in January by Tavasoli and Norris. This article had a study about 60 endometrial stromal nodules where they proposed that a minor marginal irregularity is acceptable for diagnosing endometrial stromal nodule, which is 3 or less projections with each one measured less than 3 millimeters beyond the main mass. And this has been incorporated and adopted in the WHO classification. But what about the tumors that they don't actually follow these criteria and they exceeded, but they didn't show a widespread myometrial infiltration through the myometrial infiltration? So here comes the criteria for selecting these cases. Here, the cases were selected from one hospital and their consult service. The tumors were relatively well circumscribed, but they exceeded the criteria allowable in ESN by Tafasoli and Norris. However, the tumors did not show the widespread myometrial infiltration that's typical in most low-grade endometrial stromal sarcoma. LVI was allowed in all cases. Patients were followed up through communication with clinician or the referring pathologist. Total number of cases were 19. The median age was 54 years old. Patient presented with postmenopausal bleeding, menorrhagia. Some of them, it was an incidental finding. Some they had clinical fibroid, abdominal swelling, urinary incontinence. Only 16 out of the 19 cases were followed up for a median period of 52 months. This table is actually adopted from the article. And here we see they study 19 cases where the tumor size ranged between 10 and 150 millimeter with a median of 56.5 millimeter. The maximum protrusion beyond the main mass was between 3.2 millimeter up to 12 millimeter with a median of 4 millimeter. And we can see here it's 4, so it's exceeding the criteria for endometrial stromal nodule. LVI was seen in 2 cases, and interestingly, these cases that show LVI, they didn't show mets or recurrence on a follow-up. 5 cases, they show infarct type necrosis. The variant patterns arranged between endometrioid glands in one of the cases. 5 cases, they show 6-chord differentiation. 5, they show smooth muscle differentiation. 2 of them, they show epithelioid morphology, and 2 of them, they show both 6-chord and smooth muscle differentiation. The stage at the time of the diagnosis was FIGO 1. And on a follow-up, only 2 of the 16 that they were followed up, they show mets, one at 23 months and the other one, it was at 135 months. This is one of the cases microscopically, which we see here, low-grade cytology, proliferation, and we appreciate here the protrusions around it. And CD10 was done on this tumor, and as we can see here, it's positive. It's diffusely positive membranous and cytoplasmic staining, and it's positive also in the protrusions, which prove that these are actually from the tumor itself. However, Desmond, on the other hand, it was negative in both the tumor and the protrusions, which rule out hypercellular leiomyoma. So briefly, 2 of the cases, they had recurrence. One patient, she had at 23 months mets to the small bowel and the peritoneum. Originally, the maximal infiltration, it was 4 millimeter. The other one at 35 months, she had mets to the humerus. Originally, she had minimal infiltration beyond the tumor. Only 1 patient in this study died due to unrelated diagnosis. 2 patients, they demonstrate LVI. However, these patients, they didn't show any recurrence or mets on follow-up. Out of 16 followed patients, 2 of them, they show metastatic, which is approximately 12.5%. So these tumors should consider potentially malignant. All tumor, they were staged FIGO 1. at the time of diagnosis. 9, they measured 5 or less and were stage FIGO 1A. 10 were measured more than 5 and they were stage FIGO 1B. Only 3 patients received adjuvant therapy following the initial diagnosis in the form of aromatase inhibitor letrozole. So it's very important prognostically to distinguish between the endometrial stromal nodule and low-grade endometrial stromal sarcoma. Endometrial stromal nodules, they are benign, they don't recur or spread. Low-grade endometrial stromal sarcoma, however, they have low malignant potential, they can recur, they can spread to other organs. There is a small number of low-grade endometrial stromal sarcoma, which are relatively well circumscribed. They exhibit greater than the marginal irregularity allowable in ESN. However, they don't show the widespread myometrial infiltration that's characteristic for low-grade endometrial stromal sarcoma. And currently, these tumors are categorized low-grade endometrial stromal sarcoma, and they also have been termed in the literature endometrial stromal neoplasm with limited infiltration. Dionigi, in their study, they were the first to introduce this term. They had a study, a large study of endometrial stromal nodules. 3 of these cases, they had low-grade endometrial stromal neoplasm with marginal irregularity, which is exceeding the allowable in endometrial stromal nodule, but they didn't show the widespread myometrial infiltration. Only 1 of these 3 was available for a follow-up, and it didn't show any evidence or recurrence or mets. Then, so in their study, they actually also reported a case of endometrial stromal tumor with limited infiltration, where they had more than 3 projections, but none of them, they measure more than 3 millimeter. A little else in the literature, and these cases also provide an evidence for the argument that the endometrial stromal tumors with limited infiltration harbor a malignant potential. Strength and area of improvement. I think this study is large cohort study of a rare entity. However, only selected slides were available for examination in the consult cases, for which more information about the total number of protrusions of each tumor is actually needed. It's a rich addition to the literature as it provides information about a rare entity. It also provides understanding of the clinical behavior of these tumors. Thank you, everyone, for listening.
Thank you, Dr. Ben-Khadra. That was really excellent presentation here. I'll go ahead now, and since we're getting close to the end of the hour, we'll launch the polling questions for everyone, and for everyone on the video, I will bring them up as well. Okay, I'll give it just a few more moments. Okay, I'll go ahead and share the results just in the interest of time. So now we'll review the questions. The first was, which of the following is true regarding endometrial stromal neoplasia? And that third question, or the third answer, is really the key, that myometrial infiltration does distinguish these 2 entities. Immunohistochemical staining and molecular studies are not quite as helpful. And most low-grade ESS does show extensive myometrial invasion. So, and then the second question, which of the following is a conclusion of this study? That second answer, all stromal tumors with limited infiltration should be considered as potentially malignant, just given the findings that they showed here and that Dr. Ben-Khadra summarized. Vascular invasion was not associated with many of these tumors. And then the cases were not high stage, and some of the tumors were bigger than 20 millimeters. So I was trying to sort of drive home those selected points, especially since Dr. Khadra emphasized them in her presentation. So I will stop sharing the results, and then now we'll have time for questions. So there was one question that I tried to answer in real time, but I don't think I actually did. Let's see. They were talking about, let's see. It was, Yev, it was your article, but they were asking if PEComas should be staged as epithelial or sarcoma according to the FIGO staging and CAP staging. Do you want to? I can answer it if you'd like, but
I would, if you can go ahead, I would appreciate it.
That's fine. So, you know, when you look on the CAP staging, and I actually did look because I wanted to make sure I was saying the right thing, the PEComas aren't really on the sarcoma one, but that is where I would put them. They are in the comments section. So I would assume that you would stage those, especially malignant tumors. And then, you know, I just wanted to thank all three of you. And I think a theme that runs through all three of these papers is something that we see a lot at Journal Club, because, you know, we try to pick articles about things that you might not encounter in training, is that these are uncommon lesions, and the best way to study uncommon lesions is to gather a bunch of them together, right? And the people who can do that are the people who see consult cases. So that's a good thing to file in the back of your mind if you're thinking about where you might want to train. If you want to be someone who sees these exotic lesions, you have to go where people are sending them. So Dr. McCluggage is someone who is excellent at aggregating these rare entities because of his consult service. But then, as Dr. Khadra talked about, you know, once you're a consultant, you don't have the same access to clinical information, to the gross reports, to maybe the specimen, obviously, to sort of satisfy your curiosity about the ins and outs of all the cases. So it's a compromise. And in an ideal world, we would be able to just openly share all of these cases, but we know we can't do that. I'm looking here. For uterine discus should be staged. Oh, okay. Are the ICCR guidelines? I'm sorry. Thank you. Dr. Raven put that in the comments. So that's another thing I should always check. I should forget to do that. I'm such an American. Big apologies to our worldwide audience. And then the other thing is that all three of these articles do a really excellent job. Two of them do have molecular findings. Dr. McCluggage's article is a morphologic article, but we always try to emphasize at Journal Club, just because we have such a worldwide audience, that morphology is very important. Now, Dr. Goyette, you shot a big hole in that. That's fine. That's fine. Sometimes we have to admit that we don't have the answer on morphology, but it is always important to remember that in resource limited areas of the world, IHC and molecular studies are not always available. And so sort of reinforcing, even if you're doing a molecular study, which I think both of the papers that had molecular heavy findings did an excellent job of first starting with morphology and talking about how you include cases on morphology and what folks who are relying on that exclusively, how they can handle that. And some of the places in the world, you know, the options are like really standard chemotherapy or no treatment, because they don't have these directed therapies like we do in some other parts of the world. So, okay, I think you all did a really good job. Mesenchymal month is always very popular, so good job. Do any of you have any closing comments or questions? No? You survived. Okay. All right. Thank you everyone for joining us. And please remember to fill out your evaluation. It should come up on the screen when you exit the meeting. And we'll see you next month. Thank you.